Good morning, dear colleagues. Welcome to Neurology Lecture, Infections of the Nervous System. First of all, we will speak about meningitis, which is inflammation of the meninges. Clinical features of meningitis include infectious signs and meningeal signs. Common causative bacteria usually include Streptococcus pneumonia, Pneumococcus, Neisseria meningitidis, Meningococcus, Haemophilus influenza, Haemophilus. Meningitis can be caused by bacteria, virus, fungus, protozoa, but bacterial encephalitis is more severe. Possible signs and symptoms of meningitis may include sudden high fever, neck stiffness, severe headache that seems different from usual, headache with nausea, vomiting, confusion or difficulty concentrating, seizures, sleepiness, difficulty walking, sensitivity to light, photophobia, no appetite or thirst, skin rash in case of meningococcal. In newborns, high fever, constant crying, excessive sleepiness or irritability, inactivity or sluggishness, poor feeding, bulge in the soft spot of top of baby's head, frontal, stiffness in baby's body and neck, and difficult to comfort. This is how we check neck stiffness. We try to bend the neck and bring the chin to the chest. Kernig sign, first of all, will flex the leg in knee and hip joint, and then we try to extend it in the knee. It's impossible to do. Brudzinski sign. When we try to lift one leg, we see if the other leg involuntarily flexes. Or if we bend the neck, we also see if the legs involuntarily flex in the knees. Treatment of bacterial meningitis will include urgent hospital admission, antibiotic therapy, third-generation cephalosporins like cefotaxime or ceftriaxone, benzylpenicillin if meningococcal infection, or cefotaxime or benzylpenicillin for pneumococcus, rifampicin for Haemophilus infection, benzylpenicillin and gentamicin or cefotaxime alone for Streptococcus. Vital function support, oxygen, increase of volemia, nutrition, special care. Corticosteroids to reduce edema of the brain and meninges. General measures such as antiemetics, anti-seizure, anticonvulsant. The next part, when not the meninges but the brain itself is inflamed, it's encephalitis. Encephalitis is inflammatory disease of the brain parenchyma caused by the infectious agents. Encephalitis can be caused by bacteria, virus, fungus, protozoa, but viral encephalitis is more common, on the contrary to meningococcal. Due to the action of pathogenic organism, encephalitis can be subdivided into primary and secondary due to the time of development, acute, subacute, and chronic. Primary acute encephalitis is caused by different action of pathogenic organisms. Viral infection causes neuronal and glial damage with associated inflammation and edema. Secondary encephalitis, allergic or post-infectious and post-vaccinal, is explained by indirect influence through the immune system. Encephalitis following childhood infection, such as measles, varicella, rubella, is post-infectious and usually is not due to direct viral invasion. Common viral encephalitis causes can be mumps, herpes simplex, varicella zoster, Epstein-Barr, arboviruses, and others. Clinical features of encephalitis will include focal signs and symptoms of the brain parenchyma involvement or local signs, general signs of brain involvement such as headache, consciousness disturbance, general infectious signs, pyrexia, fever, myalgia, intoxication. Sometimes symptoms of specific virus can be noted. And sometimes meningeal sign in case of combined meningoencephalitis. Focal symptoms will depend on the site of lesion. If lesion is in hemispheres, can be coma, confusion, dysphasia, hemiparesis, involuntary movements, and epilepsy. If in cerebellum, usually it's ataxia and dysarthria. If in brainstem, cranial nerve pulses, nystagmus, tetraparesis. If in midbrain, as part of brainstem, oculomotor palsy and autonomic disturbance. Herpetic infection of the nervous system may cause different lesions such as herpetic encephalitis, shingles, ganglioradiculitis, and cranial nerves ganglioneuritis if it affects cranial nerves. Herpetic infection in humans usually is caused by viruses of herpes simplex of first and second type and varicella zoster virus. First type causes oral labial rash and encephalitis. Second type, genital neonatal infection and meningitis. Herpetic encephalitis is a worldwide disorder occurring at all seasons, affecting all ages. General symptoms at onset will include headache, fever, pretty fastly developing, seizures, impaired consciousness, psychiatric disorders such as aphasia or apathy. Clinical features also include focal symptoms if inferior frontal and temporal lobes are selectively involved, olfactory and gustatory hallucinations, behavior disturbance, complex partial seizures, temporal lobe epilepsy, dysphasia, speech disorder if dominant hemisphere is affected, hemiparesis, hemiplegia. Also, except for focal symptoms, we may observe cerebral edema, which sometimes may lead to tentorial herniation and loss of vital functions. Investigations, neurovisualization, neuroimaging helps to differentiate with different lesions of the brain such as abscess and tumors. CT scan shows low attenuation in the inferior frontal and temporal lobes, but sometimes it's normal in the beginning. MRI is abnormal earlier and shows bilateral temporal lobe and limbic involvement, sometimes with hemorrhagic changes. You can see low attenuation. More on the left. In CSF, it reveals lymphocytosis, sometimes mild elevation of protein, glucose will be normal, immunoglobulins G may be elevated, and oligoclonal bands will be present. Viral-specific antibodies will appear in serum and CSF. Shingles. If the virus involves dorsal root and ganglion of the spinal cord or cranial nerve ganglion, it will lead to ganglioradiculitis or ganglioneuritis. Patients usually are over 50, sometimes maybe in younger immunodeficient patients. Often occurs in association with compromised immunity, lymphoma, cancer, AIDS, diabetes mellitus. Initial signs will include tingling, feeling, itchiness, or pain in the skin in a specific area. After a few days, vesicular skin rash appears associated with a burning, painful sensation. Vesicles contain clear fluid and usually are at the specific dermatome. After 1 to 3 weeks, the vesicles crust over and may leave irregular skin depigmentation with scarring. Here you can see how the dermatome is located with the rash, but it is, in this case, covered with the brilliant green medication. Here how it looks like on the trunk, on the extremities, or on the face. Trigeminal ganglionitis, usually ophthalmic division, is affected with vesicles above the eye and may lead to corneal ulceration. Geniculate ganglionitis, vesicles within the external auditory meatus and the eardrum. Diagnosis will be based on clinic. Although shingles can be painful, it is not generally dangerous to healthy individuals. The rash and pain goes away. Contact with a person with shingles may cause chickenpox, but not shingles. For treatment, we use acyclovir, especially for encephalitis, 30 milligrams per kilogram a day in divided dosage. It reduces mortality. Treatment for shingles is not that severe. Mild disease usually requires symptomatic treatment. In severe cases, immunodeficient patient with ophthalmic vesicles, acyclovir will be prescribed. Poliomyelitis, an acute generalized viral infection affecting the anterior horn cells of the spinal cord and motor nuclei of the brainstem. Causative virus is a poliovirus, which is an enterovirus. Coxsackie and echoviruses are the enterovirus, may produce clinically similar picture. Poliomyelitis used to be one of the major causes of paralysis and death more than 30-50 years ago, but now it's rare since the introduction of the vaccine. But nowadays, we consider that similar clinic is caused by Coxsackie and echoviruses. Mode of transmission, fecal-oral route, then causes multiplication of the virus in nasopharynx, incubation and penetration of gastrointestinal tract with viremia. It has worldwide distribution, but usually in it used to be a worldwide epidemic. Prophylactic vaccination has produced dramatic reduction in its incidence. There are 4 stages of the polio. After each stage, disease may stop or progress to the other subclinical stage. Mild non-specific symptoms of viremia with fever, sweating, malaise, headache, gastrointestinal upset. Serous meningitis in pre-paralytic stage with headache, features of meningism, irritation of meninges, back and limb pain, muscle tenderness. And paralytic stage. If brainstem is affected, it will affect motor nuclei and cause pharyngeal, laryngeal, lingual, and facial weakness or oculomotor weakness. In spinal form, when anterior horn is involved, it causes paralysis, widespread or localized, ascending or descending, proximal and asymmetrical development during one day. Monoparent tetraparalysis. You can see how it's well widespread and how it used to be very widespread. Diagnosis includes clinical manifestation and CSF examination, though can be normal or polymorphic nuclear cells and lymphocytes. Increased protein elevation with normal glucose. Serological tests and viral cultures from throat, washing, stools, CSF. Prognosis in epidemics is not very good. Improvement of muscle power usually commences 1 week after the onset of paralysis. Only a proportion of muscles remains permanently paralyzed, and the affected limb bone growth becomes retarded with shortening and thinning of the extremity. The patient is kept on bed rest, fluid balance, respiratory failure will require lung ventilation. Development of deformities is important issue and will need physiotherapy and orthopedic assisting. And we try to control symptoms while infection runs its course. A significant proportion of polio patients develop late sequelae, often 30 years after initial illness, fatigue, myalgia, and new weakness. Prophylaxis includes Sabin vaccine of choice, attenuated live virus oral vaccine, or AIDS. A moment of the nervous system and human immunodeficiency virus. Neurological disease develops at 1/2 to 2/3 of patients with HIV infection and can occur at any stage of the infection. In some cases, there may be initial manifestation of AIDS. Primary HIV infection of the nervous system may include acute reversible encephalopathy, acute aseptic meningitis, cranial neuropathies, acute myelitis, inflammation of the spinal cord, AIDS dementia. Also, it includes opportunistic infections of the central nervous system, for example, toxoplasmosis, cryptococcal meningitis, or herpetic infection, as we just discussed. Neoplasmosis, primary CNS lymphoma and Kaposi sarcoma. So, multiple sclerosis is not directly infectious disease, but it is also included in this lecture. Sclerosis disseminatus, or multiple sclerosis, is a progressing inflammatory demyelinating disease. You can see that more it's met closer to the poles. More women than men will be affected. Diagnosis is usually between 20 and 40 years old. It's rarely diagnosed in childhood or after 55. Etiology is unknown, but different theories explain multifactorial development. Infection is considered to be the trigger factor for the people with genetic predisposition. Multiple sclerosis results from autoimmune inflammation. Antibodies against myelin are produced. They destroy the myelin covering of the nerve fibers in the central nervous system. The sites where myelin is lost appear hardened, scar areas, plaques. The speed at which messages pass along the nerve will be slower than normal, even after remyelination. Symptoms of multiple sclerosis depend on which areas of the white matter in the CNS the lesion will develop. The set of symptoms vary from time to time and may change in severity and duration in the same person. But sometimes we see specific signs. For example, central pulses if upward neuron is affected, with monoparesis, paraparesis, hemiparesis, quadriparesis, with hypertonicity, hyperreflexia, pathological reflexes, Babinski sign, and clonosis. Sensory disturbance will be a result of impaired conduction through sensory pathways. Paresthesia, tingling, numbness, pins and needles, burning sensations. Pain, especially facial pain, such as trigeminal neuralgia or muscle pain because of spasticity, and loss of sensation. If extrapyramidal system is affected, it will lead to balance and coordination problems, ataxia, tremor, vertigo, clumsiness, lack of coordination, slurred speech. In case of visual nerve, optic nerve involvement, it causes optic neuritis, blindness, or double vision diplopia if it affects oculomotor nerves. Bowel and bladder problems such as need to pass urine frequently and urgently, incomplete emptying, constipation, Sensitivity to heat. Heat or hot bath often may cause transient worsening of symptoms. And Lermite sign is typical. Sudden neck flexion causes shock-like painful sensation in the back and limbs due to a moment of posterior column. Cognitive and emotional disturbances include loss of short-term memory, loss of concentration, reasoning, and mood changes, aphoria or depression. Clinical courses will include relapsing remitting course, primary progressive course, secondary progressive course, and progressive relapsing. Relapsing remitting course, periods of attacks and relapses. Primary progressive, disease progresses from the very beginning with temporary stable periods during which symptoms will remain. Secondary progressing starts as progressing remitting and then starts gradually increasing. And progressive relapsing course. There is no straightforward positive and negative test. It's a clinical diagnosis based on observing the patient's symptoms and confirmed by MRI scan. At least 2 different areas of the central nervous system will be affected, at least 2 exacerbations, at least 1 month apart, and usual age. Magnetic resonance image shows us the plaques, white spots in the white matter, usually often periventricular, near the cerebellum, near the ventricles, and also leads to atrophy of the brain after several years. You can see that ventricles are white. In the spinal cord you will also see plaques similar. Lumbar puncture. If electrophoresis of CSF is done, it will show discrete oligoclonal bands, but only in 95% of established disease and 60% after the first attack. Mild pleocytosis, possible elevation of total protein and gamma globulin increase. Treatment includes treatment of exacerbation, prevention of exacerbations, and symptomatic treatment. Treatment of acute exacerbation is pulse therapy with methylprednisolone intravenously for 3 to 5 days. Steroids give anti-inflammatory, anti-autoimmune effect and reduce inflammation and demyelination. Prevention of exacerbation, disease-modifying treatment, is when we try to slow down the development of the disease. The first-line medications are interferons and the second line are immunomodulators. Fingolimod. Or monoclonal antibodies, natalizumab or glatiramer acetate. So first line are interferons and glatiramer acetate, second line monoclonal antibodies. And metoxantrone is the last line, the third line therapy. If there is no effect from the previous therapies, it's cytostatics. And symptomatic or supportive treatment, which includes, for example, treatment of spasticity by antispastic drugs, Miclofel. Symptomatic treatment of depression, antidepressants, treatment of pain with analgesics, or if it is trigeminal neuralgia, then anticonvulsants. Prognosis, though this disease progresses and there is a risk of handicapsy, prognosis is not that bad in the beginning. Unfavorable prognostic factors are primary progressive course, late onset, polysymptomatic start, early involvement of cerebellum. Favorable prognosis, if disease will slowly develop, early onset female gender, remitting course beginning from visual disorders and long remission after the first relapse. Patients with multiple sclerosis need not only medical help, but also constant psychological and sociological support from their relatives and society. If you have any questions, you will ask them during the practical class. And thank you so much for your attention. Please take care of each other and yourselves and stay safe. Bye-bye.